asthma, phenotypes and endotypes. So, thank you. So, who uses asthma phenotypes and endotypes in clinical practice? Show of hands. Who phenotypes their patients? So, some of you. Maybe, do you find that there's a clinical application for asthma phenotypes and endotypes? Is this something that's relevant even? So I'll explain to you where do the terms come from, what do they mean, because it's a complex heterogeneous disease. There's not just one asthma, there's many different asthmas, and the goal is to find specific therapies for individual types of asthma. I have a big list there. I'm trying to explain to you different phenotypes and different endotypes that we have some evidence. Many of these don't yet have a clinical application or a biomarker that I can identify that phenotype or that endotype, but that's the goal. There's many more mechanisms at play. This is by far, I'm not going to be able to explain all the different endotypes that are being now researched. I gave this talk about 5 years ago. I've tried, for every single slide, I've tried to come up with updated evidence since the last time that we spoke from the individual groups that are researching that particular endotype. So I hope this is of interest to you. This is a CME question. It has to do with anti-Marco antibodies and which asthma phenotype it correlates with. So what's a phenotype? It's a set of observed characteristics. So they result from gene and environment interactions. Examples are atopy. Dr. Sharoon explained this morning how do you measure atopy in someone. Obesity, you can measure BMI. You can quantify this. You can observe it, right? But an endotype is defined by a distinct functional pathobiologic mechanism. Notice that I'm putting an asterisk on the two examples that I'm giving. Eosinophilic or type 2 high, Th2 high. There's an asterisk. Why? Because it's an incomplete definition. It's not really an endotype, and I'm going to explain myself. And I'm going to tell you where the research is going so that we can better identify endotypes. A bunch of these slides are from Tom Casale. This one's one of them. I think this is a good example, a good analogy. So from anemia. So that's the disease, just like asthma is the disease. But there's different phenotypes to that anemia. For example, you can measure hypochromic or hyperchromic. You get that from a CBC with diff, easily measured, observable, right? But what is the endotype? What is the cause for the hypochromic anemia? It can be iron deficiency anemia, or it can be something like beta thalassemia. In asthma, we wish we could say, oh, it's neutrophilic asthma, and therefore I'm going to measure IL-8 in serum, and therefore I'm going to diagnose the endotype. That's not quite yet there, like there is iron deficiency anemia. This is what we have now. This is what we're working with. This is now dated from 2011. And this is the consensus statement for what is an endotype. Must fulfill 5 of these 7. But you'll notice that none of these still, except for genetics and maybe biomarkers and maybe histopathology, really get to that point of what is the functional mechanism? What is the pathobiology, right? Because clinical characteristics, physiology, epidemiology, and a response to treatment is something very clinical, right? It doesn't really get to the underlying mechanism. So, for example, one of the listed endotypes, I'm going to argue, is really a phenotype. We say this person has severe eosinophilic, late onset asthma. I have problems with all of that, right? It's not really hyper-eosinophilic. We speak about this all the time. One of the residents has a project on this because somebody who has eosinophils of, let's say, 400 per microliter, you can detect that with a CBC with diff. But on a CBC with diff, it would not even raise a flag as abnormal. It's within normal limits, yet we're calling it eosinophilic when it's not really eosinophilia. Severity, age, disease duration, late onset, all of that, presence of eosinophils, they're phenotypic descriptions. It's not an endotype. Eosinophils are neither necessary nor sufficient, right? You can have non-eosinophilic asthma, and you can have those eosinophils being equal to 800, like you see patients with atopic dermatitis, yet no asthma. Same holds true for allergy. You have non-allergic asthma, and you can have seasonal allergies, yet no asthma, right? So presence of hypereosinophilia does not denote what is the underlying mechanism for the asthma. This is a slide. This summarizes Shilpa Tonks, one of the fellows who graduated from our program. It's a heterogeneous disease. Like Sally Wenzel would say, it's not one asthma, it's many different asthmas, right? And we can categorize it by age of onset, what we find in the sputum, different granulocytes. I'll have a slide on that. Severity, resistance to therapy, proneness to exacerbations. I'll have a slide on that. And there's other distinct phenotypes or endotypes like obese asthma and then endotype A or D, aspirin exacerbated respiratory disease. This slide, it's something very similar you saw from Michael Teng's presentation. It's busy, but the main two things, it goes from top to bottom, right? At the top is the outside world. It's the airway lumen. And every single human being gets exposed to many different things, including viruses or allergens, right? And other exposures like vaping and cigarettes. Then there's the airway epithelium. And in response to the environment, it releases alarmins and other chemicals, which instruct cell mediators important in asthma, which lead to chemicals that lead to the pathobiology of asthma, airway constriction, remodeling, like Dr. Camaredi Mercado explained. At the bottom, you can divide that right and left, right? To the left, you find allergic and eosinophilic, let's say type 2 asthma, which we've heard that term before, characterized by the canonical cytokines there are IL-4, 5, and 13. And then we have this non-type 2 asthma. Like I said before, it still sounds to me like phenotypic descriptions, right? But what is the underlying endotype? What is the underlying mechanism? For both, in this presentation, I'm going to give you some research, and I think it's exciting because it might lead to clinical application. We're not there yet, but I think it's exciting. This, Dr. Camaredi Mercado showed some artificial intelligence generated clustering approaches. So unbiased, unsupervised, let the computer cook and come up with different clusters, right? This is from Wendy Moore and the SARP-2 database. And it comes up with what you see there, clusters 1 through 5. And that has been reproduced many times over by different investigator groups and other data sets. But there's very limited clinical application to these clusters. I would still follow EPR4 and GINA guidelines to how to treat my patients with asthma and not being influenced by what the computer said. To be fair, that has a lot of potential, and coming out of the EU Biopred group in Europe and SARP, there's been clustering approaches, especially now that we have big data, especially on metabolomics, transcriptomics, genomics, all these other omics, especially when you start giving the computers large sample sizes. Neat things that we otherwise wouldn't think about start coming up. Bless you. But whether they have clinical application, not yet. It doesn't yet tell me for this patient do that. Now, there's this exacerbation-prone asthma Dr. Teng started bringing about. So this is an update to the last lecture. Before we had seen Lauren Denlinger's 2017 paper, but Michael Peters followed it up with longitudinal data in 2020. Dr. Ledford often complains, you come up with a phenotype or an endotype, but how stable is it? Does it persist over time? The main thing that I want you to take away from this slide is that peace sign pie chart, right? In green, you find exacerbation-resistant asthma, which means that these people never had, these are from SARP-3, a severe asthma research program, and longitudinal follow-up. In 3 years of follow-up, these people did not have one asthma exacerbation. In orange at the bottom, 21%. They had exacerbation-prone asthma. Every single year, they had at least one asthma exacerbation. What you see all the way to the left is called a Sankey plot. So there's a lot, and especially in yellow, there's things going up and down and moving between per year, whether or not they had a lot of exacerbations or no exacerbations a lot. But two things stick out to me, the things at the very top and the things at the very bottom. That's all I'm looking at. At the very top, you have those green people. These people, it means to me, exacerbation resistant, people who don't have exacerbations tend to continue not having exacerbations over time. And the people at the very bottom, the people who look at the blue squares in year 1, year 2, year 3, more than two exacerbations per year, they seem to remain there. The people who have a lot of exacerbations seem to continue over time having a lot of exacerbations. There's a phenotype called exacerbation-prone asthma. Why is this important? Because it's distinct from severity. People might have mild asthma, no symptoms, no symptoms, no symptoms, and then lightning strikes, and then they have an asthma attack, they end up in the ER, right? So it's a distinction between asthma severity and proneness to asthma exacerbations. What we also found is that adults are more likely than children to have lower total IgE and fewer positive specific allergen IgE. And having a lot of comorbidities, obstructive sleep apnea, GERD, chronic rhinosinusitis, especially with nasal polyps, and high blood eosinophils are strong predictors of exacerbation-prone asthma. Where does the whole thing, so who here uses blood eosinophils to phenotype their patients? Show of hands, maybe half. It all comes from this, David Price's study from the UK. This is Lancet Respiratory 2015. Essentially, I'm looking at that right there. It's the relative risk for people who have more than 400 eosinophils per microliter. It's about more than 40% higher relative risk of having an exacerbation. So again, this is the follow-up to last time. Also from David Price's study, what is the stability of the phenotype? So they found that the people who were never eosinophil high, meaning less than 300 per microliter eosinophils, remained that way, and they were at lower risk of having an exacerbation. There's about 41% that were intermittently high per year, and then there's the 46% that every single time that you measure a CBC with diff, they were high eosinophils. Curiously, there was not a big difference in terms of risk of exacerbation between those who were intermittent and those who were always eosinophil high. Since then, also, Monica Kraft got together 6 industry-sponsored from different companies, actually. I don't know how she pulled it off. Randomized controlled trials and showed that blood eosinophils and nasal polyps, which are also chock full of eosinophils, are among the strongest predictors of exacerbations. We were wondering about this. What's the other thing that used to phenotype? Who here, show of hands, uses FeNO in their offices? Just about the same people who use the blood eosinophils. So fractional exhaled nitric oxide. It's produced by inducible nitric oxide synthase, airway epithelium, upregulated by IL-13, but also other important cytokines like IL-1 beta, interferon gamma, TNF-alpha. Important thing, it's an endogenous bronchodilator, which means to me it's a compensatory mechanism to bronchoconstriction in the system. I'll come back to that in a later slide. But Bill Bussey and others did a secondary analysis of the Liberty Quest trial, another industry-sponsored trial, and found, because I hadn't found this information, what is the value of the FeNO? So the FeNO in 2020 was endorsed by the American Guidelines, EPR4, for choosing and adjusting control of therapy. And it also predicts responsiveness to 2 biologics, omalizumab and dupilumab. What Bill Bussey found was if your patient has an FeNO greater than or equal to 50 parts per billion, relative to those who have less than 25, they have about a 54% higher annualized severe exacerbation rate. High FeNO is an independent predictor of exacerbations. So this is some of the cool stuff. Mechanisms underlying the eosinophilic type 2 high disease. This is from John Fahy's lab at UCSF. The left half of the slide is old data, and the right half is in press in the Blue Journal. So essentially, if you do a CT scan with the metrics that they used, you find that this is all the way to top and to the left. People with asthma have high mucus scores. Healthy people do not have a mucus score, 0. Then you can see those slides. These mucus impactions tend to affect the same airway segments. Look at that. 2010, 3 years later, same mucus impaction, the same airway keeps being affected. It seems to be related to gene expression of MUC5AC being overexpressed relative to MUC5B, especially in those people who have the highest mucus scores. It has to do with a Eosinophil peroxidase concentrations. The people with the highest mucus scores have the highest EPO in their BAL fluid. This is new. The higher the mucus score, the more the air trapping. And you can see that it's present about 19% of this SARP-3 population. And look at just the cumulative number of exacerbations. It's in the widespread group in red. Some people have up to 20 exacerbations per year. And interventions are being proposed specifically for this phenotype that has to do with hyper mucus secretion, form thrust of maybe cystic fibrosis or bronchiectasis. But something you can also do differently about this, check to see if these people also have hypogammaglobulinemia, and because this is something that we can address as allergists. This is, remember the Wendy Moore clustering before? So in a follow-up study, she did clustering approaches by what cells are found in their sputum. And this is also from SARP-3. And you can see that cluster C and D, the ones that have green and purple, have either neutrophil predominant or mixed. They have neutrophils and eosinophils in their sputum. And they seem to have worse asthma, more exacerbations, worse lung function. But since then, there's Bill Bussey's study from 2013. They used a targeted monoclonal antibody blocking IL-17, which drives neutrophils infiltration. And now, more recently, this is December 2021, risankizumab, anti-IL-23, ineffective in reducing asthma exacerbations, even when selecting for people who potentially had this neutrophilic inflammation, and even anti-IL-23 might be harmful. So what are other potential endotypes? This is also from John Fahey's group, Michael Peters, who's now in Gilead. The IL-6 story. IL-6 is needed for Th17 skewing that drives neutrophilic inflammation. It seems to be higher in asthma compared to healthy population. The people who exacerbate the most have IL-6 high. The European group found a similar story, also high IL-6 driving exacerbations. And now since then, there's now longitudinal data to say, yes, longitudinally, if you have high IL-6 over time, plasma IL-6, the probability of over 3 years of follow-up having more exacerbations is higher. This is from Bruce Levy's lab at Brigham and Women's, and it's essentially that with the observation that serum amyloid A, acute phase reactant, also drives this neutrophilic asthma because of low resolvins, so lipoxin A4. So if you give this serum amyloid A to epithelial cells, they release IL-8, which drives neutrophils. The people who have high serum amyloid A and low lipoxin A4, you give back this lipoxin A4, and lo and behold, there's no more IL-8. If you measure this in BAL fluid through bronchoscopy, it's associated with neutrophils. And look at that, same color scheme. In purple, it's an overrepresentation. This is an endotype. These people have high serum amyloid A, they have low levels of lipoxin A4, and they seem to have worse asthma. They're coming, and they're still working on how to restore this lipoxin deficiency that they have. This is from Param Nayer's and Mukherjee's group from Canada. They've been developing this story for a while, and it's the idea of airway autoimmunity driving neutrophilic exacerbations. They measure sputum at the time of an exacerbation, and those people really tend to have higher levels of this anti-Marco macrophage receptor with collagenous structure, which is the main receptor for bacteria and human alveolar macrophages, so important. It also correlates with the number of antibiotic courses that they take per year. This is Dr. Ledford's slide. This is the only known endotype for asthma that I know of. Aspirin exacerbated respiratory disease, many different names, also NERD, because NSAID, exacerbated respiratory disease, it's not just aspirin, it's any NSAID, non-steroidal, anti-inflammatory, also known as Samter's triad, right? Asthma, polyps, usually eosinophilic, and sensitivity to that class, NSAIDs, COX-1 inhibitors. It's not allergy, it's not Mendelian, it doesn't start in childhood. Dr. Glom said it this morning, check cystic fibrosis if it's a child with polyps. Look at that. This is the mechanism. It has to do with the arachidonic acid metabolism. And those dotted blue circles are all of the different aberrations, molecular aberrations that have been found for patients with ARD. So ARD, it's a very small subtype of asthma, well-defined mechanism, but even that, it's many different ARDs, if you will. Obese asthma seems to be its own phenotype. The epidemic of asthma has associated with the obesity epidemic in this country and other industrialized countries. People who are obese and have asthma have worse severity, proneness to exacerbation, quality of life, resistance to asthma therapy. Any way that you can make your patients with asthma lose weight, it doesn't matter what method, diet, exercise, whatever. If you can achieve more than 7.5, maybe some people say more than 6% body weight loss, it helps their asthma. And we finna get grant funding to study tirzepatide, pharmacologic intervention, see if we can keep some weight off these people and make their asthma better. That figure is from Carlos Camargo's group. Before that vertical line is bariatric surgery, large California data set. The gray bars are 95% confidence intervals. They don't even touch. Look at that. They don't even touch before and after in terms of number of exacerbations per year. That is the effect of weight loss in asthma, controlling asthma exacerbations. And the last one that I have for you is from Fernando Holguin's group. He made the observation that people, especially with late onset asthma associated with obesity, that the endotype behind it has to do with nitric oxide. Remember what I said before about nitric oxide being an endogenous bronchodilator, which is a compensatory mechanism to bronchoconstriction? So look at this. It's nitric oxide. It's made from L-arginine, but people who have late onset obesity have overrepresentation of this molecule, ADMA. Look at it here. The people who are relative to those who are overweight and lean, those who are obese, have much less L-arginine, much higher ADMA. ADMA chews up this L-arginine and prevents the development of FeNO. People with obese asthma do not have this endogenous bronchodilator because it's being chewed up by ADMA. What Fernando Holguin, and this is an update to the slide from 5 years ago, he published now his pilot study in Journal of Clinical Investigation Insight in 2019. He proposed, let's hijack this system by giving these patients L-citrulline, which you can find in I'm not going to endorse the pharmacy, any pharmacy that you want to go to, right? And you can see this is a pilot, small number, right? But that they increased their FeNO, improved their asthma control, and some of that aberration that I was telling you about, L-arginine over ADMA, was reversed. And now a larger, better powered trial is being conducted. Stay tuned for that. So in summary, asthma is heterogeneous. We have limited information about endotypes that we can act on, right? And there's only a few clinically available biomarkers. And you guys, maybe half the crowd uses FeNO and blood eosinophils. And hopefully next time that we talk about this, there's going to be some more available. And as you saw, if you have anti-Marco, it's neutrophilic, exacerbation-prone asthma. I'll take any questions at the end.